I've done that before too.
Oh my God, for you!
You're driving at a bad time with the boys.
The study city was
Last time it was.
it's like steamboats, you don't see ankle injuries. Overlegged.
Okay.
Oh, it's going.
Yeah.
Take your knee out.
I'll see if I can. Jimmy, somebody really wants you over there.
Yeah. So if I was at you, if I hadn't had this down, this is confused me. It's Washington Road.
I'm assuming if this is part one,
So,
that there must be a
I
part
actually
two.
do for you. I just know you just know how it's
Yeah. That's why you make the big bucks.
And you make the schedule,
Yeah.
so we get it.
Did you get a revised schedule? I had to make some changes.
Keep it.
I think so.
Yes.
A couple of quick.
Absolutely.
Yeah, well, you know, one of the fellows left the program. You guys knew that. And so the assignment that I gave her for immunotherapy that we had, that session, there were going to be 2 sessions on that. Alice gave the first one. So then I didn't have a part 2 of that. So now we make a part 2 of this.
Lucky.
I'm going to just make 2 announcements. The first, I was in Yakima for Northwest Asthma last week, and at least for me, I learned how less good this experience is remotely. I mean, the combination of my not hearing well, tinny speakers and a computer, and sitting in a room by yourself is a very diminished experience from being here. So for anybody who can make it in person, firstly you get breakfast, get a nice spread this morning, but it's a more engaging experience, it's more valuable. The other announcement is the Quad AI meeting is coming up pretty soon, and our local community, there's a foundation fundraiser that we have on a Saturday, and it's a dinner event with social function and all kinds of things related to our society. So our local group has purchased 2 tables, Northwest Asthma one and the University another. There are a couple of, there are 10 seats at the table. The University's table only has about 7 or 8 of those spots filled, although we're committed to the whole table. So anybody else who's sort of the part of the broader community who wants to make a donation and sit at that table, let me know. Rennie, I don't know if you're coming to the meeting. I hope you're listening online. So if you want to chip in some money, you've always been generous. You don't get a free seat at this table. You get a seat at the table, and we'd love to have you. So let me know in the next couple of days, so we can fill up that table. As I was just saying, we have diagnosis and management of common primary immune deficiency diseases. We only had a 1 talk, but then I had to juggle the schedule a bit, and actually, for those of us who really don't deal with these diseases very often, those of us who do more bread and butter, conventional allergy, I'm very happy that we have 2 talks. I don't know if I'm going to say your name well. I hope I don't butcher it too much. Is it Maite de la Morena?
Maite.
Maite, okay. Some of you may not know who she is. She's the newest immunology faculty over at Children's. Came from Baylor, right?
Dallas, UT7.
Where? Dallas?
UT7.
I don't know where she came from. She's been with us here about a year.
No,
June. Oh, June. I don't even hear well up here. I better let you get on with the talk. So she's, especially for old guys like me and the other old guys sitting around this room with a couple of exceptions, this is an excellent review of immunodeficiency, our host defense systems, and she's going to do 2 talks for us back to back. June, right?
I'm not sure if this is theoretically on. I'm hopeful that you can hear me. I am really delighted to be here. I'm originally from Madrid, Spain, actually, and came many, many years ago to the States to work with Bob Good for many years. I was there, and then I did my training at USF and followed the field of primary immunodeficiency in St. Louis and then in Dallas. And so I've been privileged to join the group here, and I look forward. I know some of you already, and I look forward to meeting many of you in person. I've heard the names, I've seen your patients, so I'm happy to be called at any time and anything I can do to interact. So it's not usual that clinical immunologists get 2 hours of immunodeficiency. So I'm delighted to have 2 hours, because we usually tend to talk a lot, and then we have slides and slides and slides. So what I thought I would do today is just give you recognize some clinical patterns of immunodeficiency, and know how to initiate and interpret some of the laboratory studies. And then I'm going to focus a little bit more on some treatment modalities and some dilemmas and some strategies that we encounter. And then we'll leave that there. And when I come back next week, which is luckily it's back to back, because next week is when I talk, what I was going to do is present some real cases, and then we can discuss them and make it a little bit more interactive based on what we've talked today. So human diseases have been teachers of immunology forever, and a classic example are patients with multiple myeloma, for example. They develop the classic infections with encapsulated pathogens. In contrast, patients with Hodgkin's lymphoma will develop infections with pathogens that are related to many, particularly intracellular pathogens and viruses, for example. And so this observation, this clinical observation, and all of us here are clinicians, was first made by Bob Good. And that really, what he recognized was that humans had evolved to develop unique pathways that dissected really the microbial universe, if you will. And so what that led to is obviously the recognition of the classic effector cells of the adaptive immune system being B cells and antibody production, critical in the clearance of encapsulated pathogen, and of course T cells critical for intracellular pathogens, and of course clearance of certain viruses. And so for many years we've been taught simplistically that there are 4 arms of the immune system. There are the B cells and T cells, which are the effector cells of adaptive immunity, and of course your phagocytes and complement. And from the very beginning, these 4 arms were sort of described. And the beauty of these, this simplistic pattern is that there are laboratory studies that can recognize, can identify each one of these components, and each one of these components have a unique clinical phenotype. So it's in a very simplistic manner, if you really kept these 4 separately, you can really recognize both T cell deficiencies, B cell deficiencies, defects of phagocytic function, and your complement system. And if you think about it, over the years, the laboratory analysis that has led to really recognize all of these really not dramatically changed. They have improved, and certainly flow cytometry has dramatically changed how we perform a lot of these many functional studies. But in general, we still are using tests that were used almost 60 years ago. And the important thing about that is that they have been standardized. So the reality is that anybody can really make the diagnosis of a primary immunodeficiency, and it really doesn't need for a patient to be necessarily seen at a big institution. Anybody can really do that. Now, what has happened in the past, I would say 15 years, is that there's been incredible advancement in novel technologies. And so what you can see here is, this is a figure from the most recent International Union of Immunologic Society classification of immunodeficiencies, that on the top bar, defects of immune dysregulation, autoinflammatory diseases, and innate immunity have been incredibly advanced in our recognition as a defect of immune function. We always thought, and in the beginning, defects of host defense, obviously, but we now understand and it's better appreciated the role of the immune system in human autoinflammatory conditions or immune dysregulation. And these conditions perhaps maybe could be triggered initially by an intercurrent infection, but in general they may not necessarily. We really don't find pathogens that sort of guide you. And what I mean by novel technologies, I mean exome sequencing, whole genome sequencing, and gene chips available now. And certainly what has happened is that while most of the classic X-linked disorders here have not dramatically changed, there's been a boom in the recognition of autosomal recessive and autosomal dominant disorders. And these autosomal recessive disorders are very rare and many times just described in a family or so, many times the consanguineous relationships. And what happens is that, you may not see, and none of us may see some of these conditions, but they do tell us a critical an important part of a immunologic pathway that is critical for perhaps not necessarily survival, but certainly for normal function. And so this boom, especially the genetic era, has really changed the way we look and the numbers. So the reason we like to give at least 2 talks is because there's so many of them, it's hard to keep them all straight. And there's now over 250 disorders, there's over 240 genes that have been identified. And what we're recognizing is that certainly there's new genes and new phenotypes that are described, but there are also new phenotypes of old genes. So now you can make the diagnosis of severe combined immunodeficiency in adolescence, in adulthood. So we are starting to learn that there may be a lot of much more variability in the clinical phenotypes, and we'll talk about some of those next week. The other thing that has really dramatically changed is our ability to recognize that it's not just loss of function of a protein, but sometimes the gain of function, mutations that result in gain of function. So there are new genes that are associated with loss of function and of gain of function, and some examples are noted in your slides there. So what has happened is that, there's a group, there's the International Society of Union of Immunologic Societies that have come together as part of the PIDDS, immunodeficiency experts, and felt that given this advancement, given our recognition that of diseases of immune dysregulation, of autoimmunity and autoinflammation, perhaps we need to be thinking about and changing the name from primary immunodeficiencies to inborn errors of immunity. I think that's going to take a long time to sink in because we have 60 years now of primary immunodeficiency and definitions, so I think it will be difficult, but it may happen. So there are many PID phenotypic diagnoses or classifications, and you can get them on your iTunes and Androids, and you can download them, and that's one of the advances. And I've given you an online website that you can go to, which is the the IUIS website, where you can actually get the most updated classifications. And one of the beauties, and this is a mistake in your slide, because I've given you 2 papers, and I'll bring the correct reference next week, but both papers were published in Journal of Clinical Immunology last year, and this is the most updated classification of immune deficiencies. And the beauty of that paper is it's a great reference paper because you have the phenotype, the disease, you have what the T cells and B cells look like, and you have some key clinical features that might help you sort of think about, for example, if you see a patient with neurosensory hearing loss and the T cells are low, it might help you guide your thinking through that. But importantly, there's another paper which is, it looks exactly the same, and it was published back to back, which is also IUIS, but this one describes phenotypes. In other words, this is a very important tool, I think, for clinicians, for those of us who see patients in the front line, to really look at the clinical phenotype, and it helps you sort of break down how to work up a patient and what are the things that you need to be thinking about based on the clinical manifestations. For example, recurrent fever syndromes with some GI manifestations or some rashes, etc. So all of that put together, there's been a great effort at trying to put these phenotypes together, and are very, I think, very helpful. And I like to use have those fellows carry these around with them. If you want to know who are the people that make these decisions, well, here they are. And I just wanted to point out two of our colleagues, Troy, of course, and Hans, are part of this. And as you know, Steve Holland was here a couple weeks ago. So these are the people that form part of this International Immunologic Society and are the expert committee on primary immunodeficiency. Importantly, there is really an international group, including France and Israel and Australia. So it's not just within this individuals from here. So in terms of epidemiology, we have learned a lot over the last, I would say, 50 years. And while some diseases and some diagnoses really haven't changed that much, like IgA deficiency, for example, we do know that with newborn screening for severe combined immunodeficiency, the incidence of SCID now has changed. And so we thought it was 1 in 100,000, and now we know it's about 1 in 40,000. And depending on the states, it's different. So I think that's an important and great advancement because we were very many of these carriers before. There's diseases like XLA that we really don't understand the incidence. We think it's 100,000. But CVID, based on some registry data, it looks like it's much more prevalent than we thought before. Maybe 1 in 25,000. Maybe some series 1 in 50,000. But the reality is that they're not as uncommon as we think they were. Some, for example, like hyper-IgM or the X-linked form of hyper-IgM, may be a little bit more unusual. But probably it's, I think the key is the awareness and the being receptive to thinking about these disorders. So this is the classic pie chart that many of you may have seen, and that sort of gives you a general sense of the different immunodeficiencies. And what you can see in this pie chart is that the majority is this blue component here. Here are your defined syndromes, like, for example, your DeGeorge or your Wiscott's. Here are your combined deficiencies, defects of autoinflammation, phagocytic defects, immune dysregulation, and innate immunity. But this is the majority. And these are your antibody deficiency syndromes. These are your XLA patients. These are your common variable immunodeficiency, specific antibody deficiency, transient hypogamma of infancy, IgA deficiency. These are the majority of patients that you're going to be seeing on a regular basis. And because of that antibody deficiency, these are in terms of treatment, you have hemoglobin therapy that is available that is going to be one of your main therapeutic options for many of these patients. So, who should be evaluated? What testing should you do? And how should you treat them? And then, what surveillance? Say you are following a patient with XLA, or you're following a patient with CID. What is the standard surveillance that you should be monitoring these patients in a day-to-day basis? So today I'm going to talk about the first three, and next week I'm going to talk about the last one. But I'll show you some real case scenarios that will help illustrate what we know, what we don't know, and what needs to still be established. So many of you have seen the 10 million signs, and just to give you a brief historical background, the 10 million signs were created almost 20 years ago as by the Jeffrey Modell Foundation, who put together a group of experts and said, okay, we need to create some awareness about immunodeficiency. What is it that we need to tell primary care physicians and frontline clinicians as to how to identify these? And so so these were the 10 recommendations, and for more severe infections, and if you had at least two of these, you should evaluate for immune deficiency. Now, there's been no prospective study that looks at the specificity and sensitivity of these 10 warning signs. But there have been several retrospective analyses looking at the validity of these warning signs. And what we know for a fact that the most important ones have been a family history of immune deficiency, the need for intravenous antibiotic therapy, that is a good predictor of particularly parasitic defects, and in pediatrics, failure to thrive of an infant. Those are the three most important and really are predictors. All the rest have very low sensitivity and specificity. And just to give you an example, the McGinnity paper here from 2011 looked at referrals of about 140 plus patients to a primary center, a referral center, and they and said, well, can we validate what's the sensitivity and specificity of all of this? And they found it would have low specificity and sensitivity. However, if you've looked at the series of XLA patients and you looked at the series of CVID patients, all of them had at least two of these signs. So I still think that these 10 warning signs really, from a clinical standpoint, are valid and important to figure out. So who should be evaluated? Certainly anybody with family history of immune deficiency, and you would be surprised. Classic immunodeficiencies of XLA, for example, known diagnosis. Patients still don't have, family members still are not tested and only become diagnosed after many years of infections and clinical problems. So certainly the first three we talked about. But I would suggest that there are clinical patterns that are important and that really guide which one of the immunodeficiencies. And I think that if you see a patient with recurrent infections, persistent infections with unusual organisms, unusual presentations of common diseases, and now that we understand more the role of autoinflammatory immunologic disorders, unusual presentations of these and unusual presentations of malignancy, I think those patients need to be evaluated for immune deficiency. So over the years I've accumulated, I've tried to put together the clinical pattern and then the immunodeficiency. So these are some slides that I'm going to show you that I've put together over the years based on some clinical experiences. In general, the general approach is very simplistic. It's almost like go back to the simple things, the T cells and the B cells and the phagocytes and your complement. The history, recognize recognize the red flags of this history. The physical exam, you got to be able to recognize key physical exam features. Even in the pediatric world, we still don't recognize kids that have some of the syndromes, for example, some of the DiGeorge. But you will be seeing these patients as they move into the adult world. So they need to be recognized. Recognize what is abnormal. In other words, if you see a child with recurrent ear infection, sinus infection, and toddler, make sure you recognize that. If you don't see nice plumpy tonsils, that should be a little bit of a red flag to you. Think about the skin. Is this classic atopic dermatitis? And you see atopic dermatitis all the time. So if it's not responding to the way it should be responding, you should be thinking about it. Does the patient sweat? Does the patient have some ectodermal dysplasia? What are the teeth look like? Is there any evidence of gingival disease? So there are some key pearls in terms of physical exam findings that are important. And then what types of screening labs should you do? And certainly the general consensus is that because the majority of patients do have antibody deficiency, at least as a minimum, CBCs and quantitative immunoglobulins and functional analysis of specific antibody responses to vaccines. And I'll talk about that in a minute. But those are in some general terms that are sort of basic bread and butter evaluations. So here we're going to go about some recurrent patterns, some clinical patterns. And this table is certainly not, every year I might add a few more. And many times some of the individuals in the audience will give me another clue. But clinical patterns of recurrent infections. We all know about the ear infections and the sinus infections and the sinopulmonary infections and antibody deficiency syndrome. But think about innate defects. Think about complement defects. Don't just focus on the antibody defects. And if the antibody defects, if your antibody evaluation is normal, that's the end of it. No. There are other clinical scenarios that are associated with recurrent sinopulmonary infection. If you see patients with adenitis, recurrent adenitis, and maybe a history of pneumonia, think of chronic granulomatous disease. If you see recurrent boils, think of maybe hyper-IgE syndrome or chronic granulomatous disease. What about MRSA? We all see MRSA. How do you distinguish that? Well, the reality is that it's very difficult to distinguish. But unusual presentation with an MRSA, for example, an empyema, or brain abscess. I think those are scenarios where it may be important to think about other diagnoses. Recurrent candidiasis, there's a slew of different immunodeficiencies that are associated with recurrent candidiasis. And my fellows used to design mnemonic that I'll share with you next time of all the different, to include all the known candidiasis syndromes associated immunodeficiencies. Giardia is important to actually look for, because if you don't order the specific test, you're not going to recognize the giardiasis. So these are classic in patients with antibody deficiency syndromes, the classic SCIG, for example, if you're following an XLA patients. Interesting, recurrent pericarditis has been reported in patients with IgA deficiency and certainly HIV, and some of the recurrent fevers as diseases of immune dysregulation. So this is a clinical pattern of recurrent infections that I hope can be helpful. What about clinical patterns of persistent infections? So this is where the combined deficiencies come in, whether they may be very severe combined immunodeficiencies in early childhood with persistent diarrhea, persistent candidiasis, or some of these other combined defects, for example, in patients with hyper-IgM syndrome or persistent viral infections, and certainly any of the SCID babies that fortunately can be picked up before and now with newborn screening. That said, newborn screening does not pick up every single form of SCID. For example, MHC class 2 deficiency isn't picked up when we some ADA deficiencies, depending on where the mutation is, may not get picked up. Some PNP deficiency. So I still think there's a role for recognizing and thinking about severe combined immunodeficiency. We talked about the warts. Warts are really interesting, and there's a great paper in Jackie that was published by Jen Leiden several years ago, where she really looked at warts and primary immunodeficiency, and I would suggest that you look at that paper because it's a very excellent clinical paper to have as a reference. Persistent gingivitis, for example, patients with neutrophil defects commonly will have, maybe not in the younger age, but when they reach teenage years, or the adults with chronic granulomatous disease may have gingival disease as well. So in terms of screening tests, I told you about the general sense, but now because you are, you're being referred these patients by the primary care physicians, you can, we talked about the first step and the second step. I think that there is a role for including lymphocyte subpopulations and complement as that first initial evaluation. And why do I think that? Because with these tests, you can really rule out any of the severe broad-based immunodeficiencies. So you're going to rule out all your antibody defects, a classic XLA, you're going to rule out your CTID, you're going to rule out your transient hypocam with antibody production and with vaccine responses and with serum immunoglobulin. Your Wiscots are going to be picked up with a plain CBC by looking at platelets, certainly all your neutropenias, and there are many immunodeficiencies that have associated neutropenia. Kate Sullivan just recently published in the Journal of Clinical Immunology a beautiful paper of just neutropenias and immune deficiency, and to think about those. And then the reality is that when you have flow, and nowadays flow is becoming pretty standardized and almost, I would think, at first line, you're going to recognize the combined defects and some of these severe combined defects that may be presenting a little later because the genes are sort of hypomorphic mutations in some of these. All the classic complement defects are screened. So if your TCH50 is normal, all your classic complements pretty much are normal, especially in the adults. C9 may not be picked up as well with the TCH50, but for the most part, most of your immune. And some defects of immune dysregulation will be picked up because of the changes in T cell counts and variability in antibody levels. What is important is what you will not pick up with this screen. So just because you do your first evaluation and everything looks normal doesn't mean that if you feel that the patient has an unusual clinical pattern, you should pursue that because you will, you should trust your instincts because you will find the diagnosis. So what does this screening not detect? Well, it will not detect your classic phagocytic defects, your chronic granulomatous disease, any defects in that axis of when T cells activate macrophages to kill intracellular pathogens that requires that intact interferon and IL-12 axis would not be picked up. None of the TOL defects will be picked up. And TOLs are these pattern recognition receptors that are in the presence of many cells, and unfortunately we don't have a very good test. There's only one test offered in the country, and it's good to identify certain defects, but for example, toll-like receptor 3, which is associated with herpes encephalitis in later life, is not picked up well with that assay. But IRAC4 or MID88, which are important downstream pathways, can be picked up with these. Hyper IgE doesn't necessarily check PIDD. Because certainly it's not critical, but it's not essential in allergy diagnosis. So we don't really care about the IgE phenotypes. Autoimmune lymphoproliferative syndromes, it really is very dependent on how good your flow assay tests, and is it really picking up some of these doubly negative T cells that make the diagnosis, and certainly the defects of the alternative pathway. So it's important to know what the screening tools that you have are available can identify, and what it won't identify. So I'm going to show you this case. This is one of my patients. He's a 16-month-old who presented with a 2-day history of an enlarging spider bite in the right hand, and then developed a little rash on his right calf, and then started vomiting, came in shock to the emergency room. These are his labs on admission with an ANC of 117. And in less than 24 hours, the blood clusters grew Pseudomonas. And his past medical history was significant for mastoid disease and several episodes of ear infections and a lot of tubes. And and these are some pictures of this terrible Pseudomonas. What do you guys think? Would everybody stop here with neutropenia?
Obviously, the way you asked your question, no.
CGD.
So, CGD certainly, but Pseudomonas sepsis is XLA and to proven otherwise. Okay? And so, there are really important microbial red flags that would make you think about it. They're not, in this particular case, Pseudomonas. If you think about all the patients that you see with Pseudomonas and really bad lung disease, et cetera, nobody gets Pseudomonas sepsis. If you see Pseudomonas sepsis, you have a patient with either, if it's a male, think about XLA first, and if it's a female, think about agamoglobulinemia and autosomal recessive agamoglobulinemia. So, Pseudomonas sepsis really makes you think of the body art. But here are some of the other red flags, and you have it in your slides. Your pneumocystis will give you a classic patients with SCIG, with hyper IgM, certainly HIV, which is not an immune deficiency. But don't forget, sometimes XLA patients have been reported as presenting with pneumocystis as well. We talked about Pseudomonas sepsis. Certainly, strep pneumo, a patient that comes in with strep pneumo sepsis, certainly we all think about an antibody deficiency, right? But if your IgG is 1700, well, it's not an antibody deficiency, so you do need to think about complement, and never forget asplenia. Asplenia is a classic presentation of some of these of encapsulated pathogen. H-flu, not unusual bacteremia in patients with C2, a complement deficiency. So think about that. And certainly Aspergillus, nocardia, and serratia, classic catalase pathogens that we see in chronic granuloma disease. So these are some just red flags, and that's why I think it's the pathogen also can be very helpful in guiding you towards those. Are you talking about adaptive immunity? Are you talking about T cells, B cells, phagocytes, or complement? Okay. So that was a general overview, a little fast overview, but let's talk about some treatment. And certainly prevention is critical, but how do you manage infections? What is the role of vaccination with vaccines? Should you recommend? I'm going to talk and give you some tips on gamma globulin therapy, and then I'm going to give you the list of patients that have undergone, what diseases do we know can be cured with transplantations, and I'll give you some updates on the gene therapy trials that are available. So, if any of you are involved in the care of patients identified through newborn screening, it's very important to, apart from the standard, prophylaxis, etc., the standard is the home care environment and making sure that these patients are protected. To such an extent that we have a safety script that Suzanne Scudder-Smith put together, and if we get a call from the Department of Health concerning for a patient with SCID, and the confirmatory testing is consistent with SCID, then these kiddos will, if we don't have an environment that is safe in terms of infection, these patients may be hospitalized until they go to transplant. Because the goal of the newborn screening is to recognize them and get them through to transplant as quickly as possible. We don't breastfeed these babies because of the concern for CMV transmission, and somehow you gotta flag that chart. I have had patients with severe T-cell leukopenias given MMR, despite the fact that you keep saying no live vaccine, so be aware and just some common practices. What about prevention? I think that I showed you the microbial red flags. I think that understanding and having a very low threshold for identifying pathogens, the patients with recurrent pulmonary disease and bronchiectasis, I think bronchoscopies and BAL to know what you're treating is important. For those patients who may undergo surgery, for example, work with your surgeons to think about whether they may benefit from perioperative or preoperative antibiotics. And in terms of vaccines, this is a great paper that Bill Scheer spearheaded and was published in the JACI in 2014, where he looked at all of the immunodeficiency and looked at the Red Book recommendations and the common recommendations by experts. And what you can see is that, for example, antibody deficiency defined mainly by XLA and CID, the Red Book contraindicates every single one of the known live vaccines. And the experts agree, for the most part, but some of them might even consider MMR, and there's no data on varicella. Now, if you look at the old literature, these patients with XLA were able to handle measles and were able to handle chickenpox. So if these patients for some reason got these vaccines, probably would be able to handle it for the most part. Certainly, all the T-cell defects require no live vaccines, but most of the patients with the George, in general, most of them will be able to tolerate vaccines. Certainly, even though there are no prospective studies that look at, what is the exact T-cell number to immunize these patients with, that will allow you to move forward with immunization. There are a lot of retrospective studies that suggest certain cutoffs for CD4 counts, cutoffs for CD8 counts, and I'll show you some of those data next week as an example.
I just want to, there may be some people here who don't know the method for newborn screening for SCID. You want to just, maybe some potential young mothers in the back here who should know what that is?
So severe combined immunodeficiency is a primary immunodeficiency that is severe because it involves both T and B cells, and that's why it's combined, and severe because it's fatal, and we recognize it as fatal before most of the time before the first year of life. And for many years, there's been a push to try to identify these kiddos at birth because most of them would present when maternal antibodies fade, and so most of them would present with infectious complications. And so for many years, the thought was, well, what can we use to try to identify these kiddos at birth that is cheap, quick, and reliable. And at UT Southwestern almost 20 years ago, as part of the HIV era, Daniel Dusek identified that T cells coming out of the thymus, in other words, naive T cells, had in their cytoplasma these plasmids or pieces of DNA that are looped out when the T cells are developing and when the T cell receptor is developing. And these little circles of DNA are called T cell receptor excision circles. And you can identify these little circles by PCRing them out because we know exactly what is moved out. And so you can actually quantitate the numbers of naive T cells that are coming out of the thymus. And so this became, then in 2000, Jennifer Puck took a whole group of patients with SCID and took regular adult patients, depleted all the T cells, and then measured it and really validated this novel methodology and created this novel methodologies for the identification of these kids. So T cell receptor excision circles are pieces of circular DNA within the cytoplasm of T cells or naive T cells. So all babies have a number of naive T cells as we grow, and the thymus involutes the number of naive T cells that all of us in this room have may be variable based on our ages.
So now it's universally done in Washington State?
In Washington, it's been done since 2014. So these are all patients that we would be able to pick up the majority of newborn screening kiddos with severe combined immunodeficiency. And currently, pretty much all of the 50 states have implemented SCID newborn screening. There are 2 states, Louisiana, and in particular, that are pilot studies, but at least they're pilot studies, and so everybody's implementing it. We're learning a lot, and I'm happy to give a different talk for SCID. That could be a full talk in and of itself. Okay, so one of the other questions is antibiotic prophylaxis. Well, the reality is that there are many studies that have looked at the value of prophylactic antibiotic for certain immunodeficiencies, and I've outlined some of them here. But what isn't here, and which is very important, and for those of us who take care of antibody deficiency patients, is there a role for prophylactic antibiotics in antibody deficiency syndrome in the patients with recurrent sinusitis, recurrent pulmonary disease, and patients with bronchiectasis. And there's some literature in the CF world, the bronchiectasis world, of the value of prophylactic antibiotics, but nobody has really done a good study, and there's a lot of pro-con debates about this at our national meeting. But stay tuned, because at CIS there's a paper that has just been presented, will be a poster that was just accepted on the prospective study using prophylactic antibiotics in patients with antibiotic deficiency. So that's going to be very important to know for the day-to-day management. Okay, let me just talk about gamma globulin therapy. And I said that I showed you that pie chart. Majority of patients have antibody deficiency, and those that have both combined and many of the syndromes are also going to have some defect of antibody production, which brings us to the realization that gamma globulin is going to be a mainstay of therapy for most of our patients. And gamma globulin can be delivered either intravenously or subcutaneously. And this is a study that looked at about 25 patients given gamma globulin intravenously, and about 18 patients given gamma globulin subcutaneously, which showed pretty fairly standard levels. And what that just tells you is that these patients can, I usually let the families make the decision as to whether they want to use intravenous or subcutaneous. It's important, if you're going to go to the subcutaneous, that you're very knowledgeable about the little intricacies, the sizes of the needles, the tubings, and I don't know how many of you may have been able to flush these tubings, but it's not easy. And so if you have an adult with bad arthritis, for example, that may not be the best way for them to, that may not be the best approach for them. So you really need to understand how this is delivered.
On the previous slide, what's the interval of the dosing to
Oh,
get equivalent levels?
Yes, I'll show you the doses of the intervals in all of them. So why is gamma globulin important? There's a group of papers that were published by Jordan Orange looking at the impact of IVIG dosing in trough levels. So obviously, the higher your milligrams per kilo of IgG, your higher your trough. And in terms, more importantly, is the higher your trough levels, the pneumonia incidence per patient year decreases. So the reality is that in patients with antibody deficiencies, higher IgG levels have proven to be associated with significant benefit in terms of infectious complications. And people have done the same meta-analysis with sub-Q infusions, which again showed exactly the same. So either giving it subcutaneously or giving it intravenously, gamma globulin provides a very important therapy for our patients. I'm not going to go into details about this, but you can switch from IV to sub-Q. Some of the products will give you these conversions. In Europe, they've done studies independent of the products. Ratios of 1-to-1 is fairly equivalent. And if you want to start with sub-Q, you can. And there are some protocols, and some people will do 100 per kilo 5 days in a row, and then go to once a week. And some people would, and this is in this particular case here, and this is 100 per kilo twice a week for 2 weeks, and then once a week. And what you can see is that there's no statistical difference in terms of serum IgG concentration with any of them. And if you're starting with the sub-Q, usually you will get to a steady state around 6 weeks or so. So your first trough levels, you should probably check them around that time. And the intervals. So the intervals can be very variable. In the classic studies, they're usually, if you're giving sub-Q, you're giving it every week. In real life, people will give it every week, people will give it every 2 weeks, people will give it daily, whereas based on the half-life of IgG being 21 days, the interval for IVIG is usually anywhere between 3 to 4 weeks. And what about a pump versus a push? So there are even studies that have looked at just doing a 10 ml push, and some people have, and Steve Shapiro shows here, that there is really not a significant difference in terms of serum IgG. But of course, if you are doing pushes, you're getting more number of injections per week than if you're doing it as a subcutaneous infusion. So, but especially some of the adults will say, well, I'll just do smaller doses more frequently and get it over with and not think about it too much. I'm not going to go into infusion rates. The only thing that you need to know, very importantly, if you have a patient on gamma globulin, you already probably know, is that the majority of the reactions are related to the rate of the infusions. So if for whatever reasons the products get changed on you and you have a patient on a very stable infusion rate, it's very important to restart it. You can't give a different, the products are not interchangeable, and you may have reactions. But like I said, for example, if you're doing subcutaneous, you can do it a push in over a 10-minute period, and usually most patients will infuse over an hour or a couple of hours on a weekly basis. Whereas in IV, it really is very dependent on the patients.
You say they're not interchangeable. Is that because the IgA differences between the products, or are there other reasons?
No, they're not the IgA, and I didn't bring in for the most part, the IgA content is very low in most products. But I think that there are different products, there's different preparations, and we have seen, when you change to a different preparations, you really need to start almost from the beginning, because you can't predict. Some patients will do fine, but you cannot predict whether patients can can have reactions to a new product if you're giving it very fast. And the most common of these reactions are terrible headaches. And if you have a patient with a history of migraines, those headaches are very difficult to manage.
Well, now with the shortage of IVIG, there's this tendency to switch back and forth what's available, and that's sort of
And
a
that's a
discouraging
problem.
statistic.
And it's a big problem for patients because of that, the need of, to really almost start from the beginning. And it's important that patients know that. And nobody should change the product on you without your permission. That really is very, very, very important. And that's one of the advantages of the subcutaneous products too, that there's less, because there's less products, there's less variability in that. Okay, how much can you infuse per site? In children, it depends on the babies, no more than 5. Some of the older kids, up to 10 mLs per site is what I usually tend to. Adults, you can infuse up to 40. And some of the newer preparations that have hyaluronidase, which really allows you to infuse much larger volumes, up to 600 volumes at one site. Importantly, if, for example, if you have patients on IVIG, you should, when you see them, you should see them somewhat regularly and ask about, are they experiencing illnesses the week before, because sometimes that might change the timing. And then monitor site reactions. The good news is the infusion reactions decrease with time. Management, I don't have time to talk about that, but we can talk about it as a case presentation and how to do that. Remember, slowing the rate of infusions. And there's 2 important adverse events. One is acute renal failure and the other is thrombosis. And I've seen both of them. And even though acute renal failure was initially described in products that had sucrose containing sucrose as a stabilizer, the reality is none of the products today have sucrose, and you can still get a patient with renal failure. And the most important contributor is whether they have underlying immunodeficiency or an calcineurin inhibitor or dehydrated. So watch out for that. And usually you see that in some of the elderly. And your thrombosis risk, again, very important. Recognize that. I've seen it in 2 patients with ITP in children, actually. While most of these thrombosis events are very rare, but they present and can be seen in adulthood. And again, it's what scenario is the dehydrated patient hypercoagulable state. For example, if you have one of your patients with XLA comes in, who's been getting gamma globulin regularly, comes in shock, treat the shock first, get the patient well hydrated, and you can give the gamma globulin later. There's no urgency to do the gamma globulin first thing.
The last point there, I was curious, this is something I know very little about. What other human blood components are in these products? Is complement in there? Are there clotting factors, kinins? What else?
So sometimes they may have, as a blood product, they may have, the amount is very little, and so it would be, for the most part, sometimes what happens is that the reactions are related to dimers that occur within the IgG products themselves that can deposit, almost like a serum sickness sometimes too. But so yes, you can have a lot of these products, but for the most part, they have been cleared and removed.
So your intention,
Really?
you're not leaving them behind for therapeutic. You're removing them.
Yeah, you're removing as much as possible and eliminating gamma globulin.
These are expensive.
Yes, gamma globulin products are very expensive.
What is a yearly management of CVID patient cost?
Well, it could be up to $100K a year, or
$8,000 to $9,000 a month in our clinic.
9,000 a
8
month.
to 9,000 a month, depending on the dose, basically.
yeah.
It's not cheap.
And there's a variability within products.
And I presume a broad variability in insurance coverage.
Insurance.
have all different situations there.
Yeah, insurance, and that's one of the biggest problems is, we have to, as immunologists, we have to be careful as to our recommendations that for gamma globulin therapies, because insurance company will read every single detail of that and limit your ability to use the product for patients that you think may be beneficial. So just quickly, these are some of the diagnoses that have been cured with hematopoietic stem cell transplant, and in general, the survival is pretty good with transplantations for those that are indicated. Of course, there's a lot of new differences depending on whether it's a matched unrelated, matched related, but certainly in general, I think this is data that I pulled up from CIBMTR for unrelated transplants. And exciting are the new gene therapy studies that are available. And so in the United States, ADA SCID is pending FDA approval, so it will be not only available in certain centers, but available to many more centers. There's a standardization in the way you can isolate hematopoietic stem cells from the individual and reinfuse them. There are clinical trials for X-linked SCID in the U.S. at Boston, Cincinnati, UCLA, and NIH, and also another group, St. Jude, UCSF, and us is the other group that are doing the X-linked SCID trials. We'll be starting the X-linked SCID trial. Artemis SCID, which is a very rare form of radiosensitive SCID, is being done at UCSF. X-linked chronic granulomatous disease is being done here in the U.S. and in Europe. And Wiskott-Aldrich syndrome, there are both in the U.S. and Europe, and we are hoping to start up as well for Wiskott-Aldrich syndrome. So that was a whirlwind, and I took every single minute of it. But I'm happy to take questions, and I thought we can, if you'd like, next week, what I have prepared are certain cases and clinical management of them, and some of the common diagnoses, for example, CDMT. But if you would like me to focus on some other issues, I'm happy to do that as well.
Well, leave some time next week for questions. Most people, I don't know if there are questions, burning questions now.
One of the slides said no breastfeeding because of concern about CMV. Can't you just screen the mother to see if she's CMV negative and let her breastfeed?
Correct.
Yeah.
That's exactly what we do.
Oh, okay.
I have a few patients with fungus whose IgG levels are already high. They had low IgA and IgM, and their antibody defects, like pneumococcal antibody deficiency. So how do you monitor these patients? I've been monitoring their infections, their IgG levels are already high, and I was worried about hypercoagulable state as well. But when I contacted HemOnc, they said MGUS doesn't really increase the chance of hyperviscosity syndromes. Have you had any experience with these patients, and how do you follow up? And
So patients, for example, to me that sounds, this is a patient on IVIG? Or?
Mhm.
Oh, on IVIG. No, I think, your normal values can be up to, 1,800, 1,900 milligrams per deciliter. So I've not seen any true sort of thrombosis, hypercoagulable thrombotic risk unless you have the associated other risks.
How
It's
about renal
usually in an
issues?
acute setting.
How about renal issues?
No, I haven't really, unless they have underlying renal disease, unless they have true, calcineurin inhibitors or medications that can contribute. I've not seen it. I've seen it in patients with calcineurin inhibitors, certainly. So those are the ones that you have to keep.
With your vaccination contraindications, why are the people with the antibody deficiencies, why do you contraindicated to use viral vaccines?
The live viral vaccines, because in general, we always think of immunodeficiency with an inability to handle any of the live vaccines. And so that's the general consensus at the Red Book. But if you look at patients with XLA, for example, the natural history of the disease, they were able to handle measles, they were able to handle varicella. But it's hard to sort of give a live vaccine to a patient that has established immune deficiency. So in the general consensus is that. Now, the reality, if you have XLA, you're not going to make antibodies. However, if you have patients with CVID, for example, the influenza seasonal vaccine is helpful. There are studies that have looked at whether these patients can make antibodies, and they certainly have been able to do that for some, shown that they can do that. So I immunize all my CVID with influenza seasonal flu.
So basically, that's contrary to sort of what the recommendations are. Since it is a live virus vaccine, they will say all, I guess not all live viruses, but I mean, I'm curious as to if it's a T cell mediated defect versus a B cell, and why would there be that discrepancy? I guess I still don't understand.
Well, the Red Book says that it's contraindicated. The expert committees say that you can consider giving it and it's not going to cause any harm. But if you have a true antibody deficiency, they can't make antibodies anyway. So why would you give them another shot?
There's a difference between is there any therapeutic benefit because they can't make a response,
Right.
versus is it dangerous to give someone a live virus and they could get disease. And those are the two rationales for why you would or would not immunize.
Remember, if you have an antibody, they're already on gamma globulin infusion, so they're already receiving.
Yeah, I guess the question I get all the time is, can I give this patient on IVIG and a viral vaccine? And that's the question I get asked the most frequently is, can they have a flu shot? Can they have this?
Yeah, they can. So it certainly, again, it depends on the type of immunodeficiency. The question is it going to do anything? Are you going to create, are you going to give them, are they going to be able to mount an antibody response? There's going to be any benefit. You're just giving them a shot without a benefit, right?
Hopefully that's not the case.
But if you have a true XLA, they can't make antibodies.
I'm not the XLA folks. It's this, I don't have many of them because I see mostly adults, but the CVID, since the protection is mediated via antibodies, I guess I would
Something you guys can break down.
Yeah, so antibodies, they're neutralizing antibodies. That's why you give them a vaccine.
You don't think it's
In general, also it's antibody. Yeah, it's basically like you're going to give them a vaccine.
Actually, are you going to the east side today?
Are you going to the east side? No, I'm not going to the east side. I went to go for me. Half an hour.
You got the brakes on.
Oh, thank you. I appreciate that.
Up right off.
Well, it's supposed to have a little hair tie on it, but apparently that popped off too. How are you, sir?
Not too bad.
I guess that makes sense.
Not too bad.
Getting around okay?
See if I can get this thing up in there. So Paul, I'd like to kind of come up and just shadow and get familiarity with the clinic.
You can come whenever you want. Just tell us when you want to come.
Well, when you're there.
When I'm there, you want to see the, you want to set the bar really low and come when I'm there. Is that what you want to do,
So I
Mike?
want to get a little familiarity with how you do things.
Yeah, well, that's not coming to see me. That's for sure.
So,
You can sort of come whenever you want.
well, but you're not there on some days.
Friday.
You're not there.
It's the only day I'm not there. So you can come any other day.
All right. Well, I'll let you know.
Okay.
I have a couple.
Come up, see where
See what life is like.
where I have to park. See if I can plug my car in anywhere.
I don't. We don't have it. I don't know if we have any electric spaces.
Well, that's what I'm sort of like.
But it's
Just
only
a wall.
It's only 20 miles to every. It's not like your
A
car's
wall
gonna run out of
outlet's
gas.
fine. A wall outlet's fine. I used to, when I worked in our Everett office, I had an extension cord. I just plugged in the wall outlet threaded it out the
Trickle
door.
charged it.
Yeah, and it's 4 miles an hour. So if you're there 8 hours, or 10 hours.
Don't you have one of the fast chargers at your house?
No.
Why didn't
So
you
why
why did you get in a fast
It's
charger?
an apartment complex. You know? We tried to get him to put in a rapid charger.
Even Stevens Pass has that right at the front door. They have a fast charger there.
Well, I have the woman friend I'm dating has a faster. It's a 220, so it charges.
So is that how you pick your women friends? They have to have a fast charger. Rest of them not going to see you again if you don't have a fast charger.
First date prerequisite.
But it's funny when you go to Whistler, if you go into Squamish behind the Boston Pizza, there's like 10 fast chargers there, and they're all free.
It's a Tesla. Tesla.
I don't know. They're all fast chargers.
They're for Tesla. Yeah.
Yeah, the white ones. Yeah. That's the nice thing. They're starting to put those rapid chargers in a lot of places.
There are a lot of
There's
places.
one at the Fred Meyer and Monroe.
That's great, but I know about the one. I mean, I just go to the one in Squamish, but I don't have an electric car yet. I'm still
You can plug your car in and go
still a
to dinner.
Subaru person. I still
Well,
like
Subarus are like the classic around here.
Yeah, but they're not electric. You still got to put gas in.
You still gotta put gas in that for sure.
But they're like little goats. Well, they have a hybrid now, but it's not.
So, Dr. Williams, I just wanted to reintroduce myself. I think you met me. Oh my God, not sorry, doctor.
See you later.
Yeah, hey, I'm sorry.
So what we need to do
Get some breakfast.
let's look and see if there are any. How do you want to do it? Do you want to look and see? Because some of the days are great and other days are not. So it might be
I
good
don't
to.
have access to.
I wonder if you could touch base with
Yeah.
to find out which are the good,
I was planning that.
what's the clinic like and what patients are there
Sure.
for you.
How many patients do you see per day?
Which one?
6 or
The
7.
anniversary or the right place?
Yeah, I was gonna contact her. I don't have access to this.
Okay.
I've been told that it's a huge stack of papers that you need to get.
So you should be able to come those, right? But, so you wouldn't have any problems.
I'll check with her.
She was ambitious. I asked her, she said that it would be fine.
Oh,
Just find out. Okay. What else?
You want sugar?
Muffin or? No, these are. Are they open? They're not open.
It's open.
Well, it's just open one. Oh, that would be good.
Thanks for all you do for little
Yeah,
kids.
thank you very much. Thanks.
Yeah.
See you next
Great
week.
spot. Thank you.
Oh, thank you.
Bye, guys.
Bye-bye.
Bye.
So,
I always feel bad not bringing anywhere, but I also always feel worried about my car when I do.
It's all about you. So they're actually fried out.
Oh no.
Yeah.
Did I leave my
Briefcase? No, whose is that?
parking ticket? I think that's theirs.
Oh, it's the groups. Supposed to take that.
Get the parking ticket.
Oh, here it is.
They make you remember so much. You got it?
Yep.
Sure. Plus all your other stuff?
Yeah. Oh, I got
Alright.
some Persona.
You're a woman of...
I have a. Oh, I don't think I brought up my parking ticket. Ha!
I remember this time. Plus, I remember the credit card. So that's.
I remember the credit card, but not